Hodgkin lymphomas. Lymphomas are the neoplasms that arise from lymphoid tissues. Lymphoid neoplasms are classified into two types: Hodgkin lymphomas and a non-Hodgkin lymphoma. Hodgkin lymphoma, it is mostly localized to a single axial group of nodes. Contagious spread, mesenteric nodes and Waldeyer rings rarely involved, extranodal involvement uncommon, and Reese-Sternberg cells present. In non-Hodgkin lymphoma, it mostly involves multiple peripheral nodes, non-contagious spread, mesenteric nodes and Waldeyer's ring commonly involved. Extranodal involvement is common, and Reese-Sternberg cells absent. Hodgkin lymphoma. Clinical features: lymph node enlargement, most often of the cervical nodes. Cervical lymph nodes are painless with a rubbery consistency. Lymph nodes are involved in a contagious pattern that is orderly anatomic spread to adjacent nodes. Hepatosplenomegaly and systemic B symptoms present, like fever, drenching night sweats, weight loss of greater than 10% of body weight. WHO classification: classic Hodgkin lymphoma. Further classified into nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depletion. Non-classical Hodgkin lymphoma includes the lymphocyte predominance. Nodular sclerosis. It is most common subtype of Hodgkin lymphoma, contributes 65 to 70%. It is the only Hodgkin lymphoma that is more common in females. Reed-Sternberg cells plus fibrotic bands. Epstein-Barr virus is negative in nodular sclerosis and prognosis is excellent. Mixed cellularity. It is the second most common type, contributes 20 to 25%, more common in males. Reed-Sternberg cells present but no fibrotic bands. Epstein-Barr virus is positive in 70% of cases. Prognosis is intermediate of the mixed cellularity. Then lymphocyte rich. It is common in old males. Reed-Sternberg cells plus abundant normal appearing lymphocytes are present. Background infiltrates means rich in lymphocytes in lymphocyte rich type. Epstein-Barr virus positive in 30% of the lymphocyte rich. Prognosis is good of the lymphocyte rich. Lymphocyte depleted. It is more common in old males. Reed-Sternberg cells plus diffuse fibrosis. Background infiltrate. Paucity of the lymphocytes is noted. Epstein-Barr virus is positive mostly and HIV is positive in few. Prognosis is worst. The lymphocyte predominant. It is more common in young males. Popcorn cells, that is a lymphohistocytic variant of Reed-Sternberg cells, is seen in lymphocyte predominant, and Epstein-Barr virus is negative in this case. Prognosis is the best in lymphocyte predominant. Staging of the Hodgkin lymphoma: stage 1 confined to single lymph node region, stage 2 involvement of greater than 2 nodal areas on the same side of diaphragm, in stage 3 involvement of nodes on both sides of diaphragm, and stage 4 extranodal involvement like the liver and bone marrow. Each stage is subclassified into absence of symptoms and presence of symptoms. In presence of symptoms includes weight loss, drenching, sweats, and fever. Diagnosis of the Hodgkin lymphoma: CBC normal or may show normochromic normocytic anemia, lymphopenia. ESR raised, serum LDH raised level is associated with poor prognosis. Chest X-ray, mediastinal widening plus minus lung involvement. CT scan chest, abdomen, and pelvis. Positron emission tomography means PET scan for staging and assessing response to therapy. Excisional lymph node biopsy. It is the most accurate test required for definitive diagnosis. It shows characteristic Reed-Sternberg cells. Reed-Sternberg cell: large B cell with bilobular nuclei with halves. Large B cell with bilobular nuclei with halves. As mirror images, owl eyes and eosinophilic nuclei. Treatment of Hodgkin lymphoma: in local disease like stage 1A and 1B, chemotherapy, ABVD regime, and radiotherapy. In advanced disease like stage 3, 4, or any B symptom, chemotherapy, ABVD regime, only 6 to 8 cycles. A stands for adriamycin, B stands for bleomycin, V stands for vincristine, and D stands for dacarbazine. Relapse after radiotherapy is equal to chemotherapy. Relapse after chemotherapy is equal to high dose chemotherapy plus bone marrow transplantation. So in relapse occur after radiotherapy, then give chemotherapy. And if relapse after chemotherapy, then high dose chemotherapy plus bone marrow transplant is the treatment.